Greetings. We're here at the Conference on Retroviruses and Opportunistic Infections, the 19th CROI in Seattle, Washington. I'm Heidi Nass, a treatment advocate from Madison, Wisconsin, and I have two distinguished clinicians, researchers with me. Will you two introduce yourselves?
Certainly. I'm Christine Patterson from the University of North Carolina in Chapel Hill.
And I'm Liz Connick. I'm at the University of Colorado in Denver.
And hopefully as we talk about information you guys have found interesting at CROI, you'll also tell us, what your specialties are and, if you found anything of interest, particularly in your areas of expertise and focus. So this is a conference where some of the best data is presented. And I'm just wondering if there's anything you learned this week that would help a woman, let's say, who is starting treatment. Is there anything new that you learned that you think someone who's contemplating treatment, let's say, or getting into care should know?
Well, I think probably the most important discovery in the last year, which applies to both men and women, is the use of treatment as prevention.
So you mean someone starts treatment for their own health and it acts as prevention?
Yes.
Okay.
I think most people with HIV have a lot of anxiety about the possibility of transmitting to a loved one, a partner who is seronegative. And now we have very convincing data that if people are taking antiviral therapy and their viral load is well suppressed, their risk of transmitting to another person is extremely low. Most people say it's not zero, and the guidelines still recommend condom use, although we don't know how necessary that is, I don't think at this moment. But in any case, I think it's just a tremendous benefit and something that if somebody is starting therapy, they can feel really good about, that they are going to decrease the risk of seronegative partners who they may have.
I can tell you as a positive woman that certainly, was just incredibly good news to me and I think every positive person that I know, honestly. And there's also a belief in the community that it will help reduce the stigma. There's terrible stigma and judgment toward those of us living with HIV that I think sometimes is underappreciated, including by clinicians I've sensed that and heard that I think sometimes physicians who take such good care of their patients, I don't know, maybe, and especially we've seen the darkest times of the epidemic, there must be a certain desire to want things to be okay, or it's so much better than it used to be. But there are still some very dark corners of this, and stigma is one of them. And so to have data like this that shows that you're not a disease vector, you're not someone who's solely walking around at risk of infecting others is tremendous. And, intimate sexual relationships are the key of, human nature, really. It's one of them, certainly.
And I think that demonstrates the power that women can have in taking control of their lives and making sure that they can take care of themselves and not worry about infecting their partner.
Yeah.
So in a sense, they're not only are receiving benefit for themselves and their partner, but also there's an added benefit in that it hopefully will relieve some of the burden that so many women carry with them.
Yeah, and the bottom line truth is that women don't wear condoms. So, condoms as a prevention method, which is really the only one we've had, is difficult for women because that means automatically you have to negotiate it with somebody else. So you're absolutely right to know that.
And not only do you have to negotiate a condom, but you have to disclose to the partner why you have to negotiate for a condom.
Yeah, or figure out some reason why you suddenly want to wear a condom or whatever. Women in married relationships have a very difficult time doing that, for example, not to mention lots of other scenarios.
Right, very difficult. So I just think it's the best news possible.
I worry sometimes people misconstrue it. They think patients are going to be, somehow put on therapy for the public good. And the way that I imagine you guys understand the data and everything we know about it is that our individual good as patients in your clinics is the priority.
Absolutely.
Right? Yeah, but I think there's a lot of human rights concerns that will people be thrown onto treatment to protect the public. But that's not the way the issue's been studied. It's certainly not the context in which it was looked at.
Yeah, I mean, the most important aspect is that individuals take antiretroviral therapy for their own health, and to be adherent to that regimen, because in the long run, that's going to help. That's going to benefit them and maintain their health, so that they can contribute in whatever fashion that they're able to. Taking care of their children, whether that's working outside of the home, caring for other loved ones, etc. And that, just by way of taking care of themselves, will have an effect on the population at large.
Sure.
But it's really taking care of yourself, and I don't think that women always make that a priority.
We're not that good at that, are
No.
we? No.
And that's just straight across the board.
Right, exactly. Yeah, all ages, I think, no
Yes.
matter how you slice it, as they say. So, Chris, anything that you learned this week that, I don't know, changes how you practice in clinic with someone starting treatment, let's say? A woman?
There was a poster that looked at drug concentrations of one of the antiretrovirals of atazanavir, and it
Rayataz, right?
Yes, Rayataz.
Okay.
Yep. And it was actually boosted Rayataz, and it actually was a continuum of an analysis that had been presented last year, and this was in a very large treatment-naive study, ACTG 5202, 1,800 participants. It was all domestic, and although this wasn't a part of the primary analyses, they demonstrated that women have decreased clearance of atazanavir, and hence have higher concentrations of atazanavir in their blood.
So you're saying, these are people who are starting treatment for the first time.
Right, treatment naive.
Rayataz with a booster, with Norvir.
With Norvir.
Is what they're on. And it moves, is it accurate to say, more slowly through their system? And so they have more of it?
Yes.
Is that accurate? And so does that mean then they might get more side effects or more things that go with it?
Potentially.
Yeah.
Potentially.
Did they find that in this study, or that's not what they were looking at? Or
it wasn't one of the primary objectives
Okay.
in this study, but it was, something that that was found, and this was actually found and presented last year from a different study, and so it's from looking at these large studies in a study that enrolled less than 20% women.
Whole other topic.
Whole other topic.
Yes.
There was only we were only able to look at drug concentrations in a small number of women, but of those small number of women, we're able to see that they metabolize drugs differently.
So then the next question is, I suppose ideally we'd have more research, more data that would show these women coming to your clinic, whether you as treating physicians should be prescribing them a different dose, or if there's any different way you should be treating them, right? But we're not there.
We're not there.
Yeah.
We're not there. But we need to be aware, and the women need to be aware that they may have some different side effects or have different tolerability issues than what is normally described to them.
Yeah, what some of their men friends might be saying, their experiences with the drug.
They may be
whatever.
completely different.
Sure.
So they just need to be honest and upfront with their provider and know that maybe this isn't the right regimen for them. And this isn't just with atazanavir, it's with any regimen.
Sure. Pay attention to how you're feeling. Treat it as legitimate and real, and bring it to your doctor.
Yes.
Sounds like that's what you're saying.
Yes, very nice.
Thank you. Any other things, Liz, that you found relevant or useful for you as a clinician?
Along the lines of toxicity, I saw another poster. It was from Thailand, actually, but they had started men and women on a nevirapine regimen. And what they found was that the women had more lipoatrophy and more rash. The rash we knew about, but they had actually needed to discontinue therapy more often, or switch therapy more often than the men because of the side effects that they were having. And I think lipoatrophy is something that is really understudied, and women suffer from much more than men. Lipoaccumulation.
Can you describe what those are?
That's the fat redistribution syndromes, where sometimes people lose the fat in their limbs, but they may accumulate it in their torso or develop a hump. And we really don't understand the biological mechanisms, but it clearly affects women more than men. And I think it's that study again brought up this is a problem that we need to know a lot more about.
Yeah, that's exactly what Chris is saying about a different drug. So this is two now we've talked about where.
And two different classes.
Two different classes, a non-nucleoside and a protease inhibitor.
Yeah.
Yeah, and the lipoatrophy in particular, and I think lipohypertrophy, the gaining of fat around the middle, are very distressing to those of us living with HIV.
Very.
You know, it's, not a great experience to look in the mirror and see the fat missing from your cheeks, your temples. I think a lot of people see it as a mark. There used to be a mark of AIDS, which was wasting, just the extreme loss of weight. And anorexia, really. And now we see this look, and people know that look. Yeah. And it contributes to stigma, right?
Absolutely.
I have to ask you both, is there information you wish you would have seen here when it comes to women and research in women that you don't see?
Quite a lot.
Sit back and prepare to chat.
How long of a list do you want?
Right.
Yeah.
Pick the top ones. We'll start there.
Well, although there was a lot about women at the conference, there was very little about American women. And I think that American women have historically been very neglected in research. We already mentioned not included in adequate numbers in drug clinical trials. And this is still a problem. And I really don't see it any improvement in terms of people willing to spend research dollars to address questions that relate directly to women, like the lipoatrophy or HRT, hormone replacement therapy for menopausal women. Is that harmful? Is that helpful? There's a big debate in the seronegative public about whether it could help or hurt, and none of those questions have been asked in women with HIV, and as more and more women in the U.S. are getting older and going through menopause who have HIV, this is, I think, a very important issue to do some research on and to address. Cardiovascular disease, there's increased risk, both men and women, but HIV-infected women, their relative risk, that is compared to seronegatives, is actually much higher than for HIV seropositive men. And we have no understanding of why is female sex not doing the same protection that it does in seronegative women.
So women without HIV, it's a different story, you're saying, than women with HIV.
It's not a different story, but the increase in risk of heart disease compared to seronegative women is much greater, the relative risk, compared to the increase in risk for seropositive men versus seronegative men. Actually, men still have more heart disease than women, both HIV positive and HIV negative, but basically the difference is much less than it was in the seronegative populations. There's something about female sex that is somehow somewhat protective against heart disease, but that enormous protection from sex seems to be attenuated, weakened by HIV. And and we don't know why.
So that seems like a good thing to understand, ideally.
Yes.
Given that as
Yeah.
women get older, their risk of heart disease
And-
goes up generally, right?
And cardiovascular disease is still the number one cause of death of women
Period.
in the United
Oh,
States.
yeah.
Across the board. It's not breast cancer, it's not cervical cancer, it's cardiovascular disease. And it's not HIV. It's cardiovascular disease. And we don't know anything or very little about cardiovascular disease in HIV positive women
Right.
who have been on therapy for a very long time, or women who have been on therapy for a short period of time. Women as they transition through menopause, younger women, older women. I mean, it's
Very
just
understudied.
understudied.
I want to talk a little more about postmenopausal women. I know that's a specialty of yours,
Yes,
Chris.
it is.
So before we do that, I want to ask you, Liz, to mention what your area of interest is, and then if you saw anything, related to that.
I have a lot of
know
areas
you
of
do.
interest.
But you do a different kind of investigation, I think, than Chris does, and I want to just make sure we talk about both of those.
Yes. Well, I've done research in primary infection, and one of the things that I thought was very interesting that relates to primary infection and HIV prevention in the U.S. was the ISIS study that was a study done by the HIV Prevention Trials Network, and their specific goal was to see, can they recruit enough women who are at high risk for HIV and follow them prospectively and be able to test an intervention. And in order to do this, they needed to identify that they could actually find
them.
women who are at risk and who will seroconvert. In the ISIS study, they recruited over 2,000 women, and they followed them for 6 to 12 months. And they did HIV testing every 6 months. And they had 4 women seroconvert, which was a 0.25% incidence, which is 5 times higher than the incidence in just the African American women population, which is the highest risk in the U.S. And I think that it does demonstrate that you can do prevention trials in the U.S. The rate of seroconversion was similar to what they've seen in some African countries. And I feel that these studies are really important to address the epidemic in the U.S. So I thought that was a very important study to come out and say we can identify people.
Yeah, that's often I think when pharmaceutical companies, for example, are challenged on this issue of where are the women, they'll often say, oh, they're not in the clinic, they don't come, we can't find them.
Yeah.
And I love studies like this that demonstrate, you actually they are there, you can find
You
them.
can find them.
And it'll help us ultimately understand communities better.
And I would just like to add to that is, it's very unfortunate. This was a very, very important study for women.
Yes.
And not only in identifying positive women, but for the communities and for the field. And the presentation did not get an oral, was not an oral platform. I mean, it was presented as a poster. And I just think that that's really unfortunate. And I think that what that says to me is that it's not a priority for many, many people. And we need to sound our voices and let people know that it is a priority. And it's a priority here in, domestically.
So that brings me to another point, but I want to come back to you, Chris, since
Yes.
postmenopausal women I know is an area of interest to you. Is there anything else you wanted to add about that? Any other things you wish we knew, or things you're trying to find out as women, age with HIV?
Even the longitudinal studies of women with HIV, they enrolled young women, and women who may have been followed for 10 or 15 years are just now starting to go through the menopause transition. And we don't understand drug-drug interactions in this population. We don't understand pharmacology. We don't understand tolerability. We don't understand, just to the basic, from the social aspects of how women disclose or not disclose, who they turn to for support or don't turn to, to all the aspects of treatment, and so it's the whole spectrum between prevention and treatment. And if we don't understand those aspects of this growing population of HIV-infected women, there's no way we're going to be able to understand how we can move towards cure.
Or maybe even how we can, in the interim, in the meantime, how we can even provide the best care possible, right? I mean,
Absolutely.
More information must help you do better when you're caring for somebody.
Absolutely.
So the question I wanted to ask you, there's an editorial in the Journal of the American Medical Association recently talking about disparities in your field, in medicine. 40 years after Title IX, which was, federal legislation that was designed to get rid of barriers to women in education, among other things. And you guys are familiar with this editorial, I'm guessing?
Very much.
Yeah, and it showed that it was about how, medical school, you're about half and half with men, but then after that, the roads start to diverge, right? So in positions of power within medical schools, as people who are applying for federal money to get your studies funded, having a lower rate of funding, and all kinds of other disparities. My question to you is, do you think that kind of disparity in your field affects women's research as a whole?
Absolutely. There's no question. I think women's health research in general is performed more often by women than by men for probably the reasons that women recognize that it's needed and have an affinity for patients who are women. And I think that's why women's health research in general has languished for many years. And unfortunately, with the tightening up of the NIH money, there's going to be a lot of researchers who are going to lose their ability to do research. And because of the sex bias in the way that grants are awarded through the NIH process, this means that more women researchers are going to lose their funding, close their labs, than men. And this means women's health research, not just HIV-infected women's, but all women's health research is probably going to suffer disproportionately because of that. It's really a mystery to me how the federal government can demand that people not discriminate on the basis of sex all over the country, but they nonetheless allow their own institution, the National Institute of Health, to continue a process that, by their own documentation, is biased against women.
Yeah, I mean, some of the numbers that are included in that editorial in terms of the disparity, whether it's salary or funding of research grants or getting funded a second time to continue the research, were pretty striking, actually. So, Chris, same feeling for you as Liz, or
right? And and it goes. There's the research aspect, but on the other hand, there's also just women are going to get discouraged, and they're not going to want to continue to stay in the health field, and so I think that we're just going to have less female providers. If there aren't women role models for them to emulate, then it's going to trickle down, and there aren't women leaders in academic institutions, they're just not brought along. to the same degree as men.
Right.
It's really, it's interesting that when you start talking about women's health, let's say, I think it would apply to other aspects of women, it starts to feel like no matter how you turn it, we were just talking about what we know about women with HIV relative to the treatment they're on, for example, or what happens as they get older, and we say, oh, we actually don't know much. And then you turn it a bit further and you say, well, are there sufficient numbers of women researchers and people interested in doing women's research? Well, not really. It's like there's all of these gaps that kind of create this gaping hole, it almost seems like.
Right. And so I think that we need to try to address this problem on a lot of different levels, and there needs to be grassroots efforts to encourage for individuals to keep asking the questions, for researchers to keep asking the questions, and trying to continue to pursue these avenues of research, and really push the envelope of what we think is really necessary information to get out there. But it needs to be a marriage between the community, the researchers, the clinicians, and the people who are providing dollars.
Yes.
But we
Well, I think
need to make our voices heard.
Yeah, I think it has to come from top down. It's not going to happen with, the people have been struggling against this for years. It really has to be a change in culture and a change in priorities. And it has to be stated, this is a priority. This is the research we want to fund. This is
what I find frustrating about the editorial in JAMA is, I think, for example, when it comes to recruiting and retaining women in clinical trials, that if there was some sort of top-down lever saying you must have a certain percentage of women in these trials that are investigating how drugs work in the body, let's say, that they would find the women, or they wouldn't get their money. But then, Title IX effectively did that and said, we see this as a priority, that we get women into our educational institutions. And it worked to a large extent.
Yeah.
But here we are saying it's not a good situation.
Well, it's a culture. There's not all NIH institutes are that way. The National Heart, Lung, and Blood Institute insists that women be equally represented in cardiovascular studies.
And I bet they find
This is a
women.
national, they do. This is a National Institute of Allergy and Infectious Disease that has not insisted that women be equally represented. But NIAID could say it. They have the ability, the authority to say, we insist on it. They simply haven't.
Sounds like what you guys are saying, we all have some advocacy work to do.
Yes,
Yes.
definitely.
Were you going to add something else?
No, I think that we can. We need to push the people in NIAID and other organizations like that to make this a priority.
FDA, right.
Absolutely, FDA. So we will not approve your drug until 50% of your participants are women, or some caveat of.
You have sufficient data to make a conclusion about the safety and efficacy of the drug in women. I mean,
So that by the time I take it, I know how it's going to behave in me as a woman, because it's been studied in other women. Right?
Exactly.
It doesn't sound like too much to ask, I have to say.
No.
It really doesn't.
No.
I want to thank you both so much for chatting with me. I know we could chat for a lot longer about a lot of things, but it's pretty clear we have a long way to go. And there's this language in our work that I think highlights what we're talking about. Women are often referred to as a special population, right? Am I right? In research settings? And for me, that's very hard to grasp, because we're actually half of the population. And I don't know, I'm sure, as individuals we're very special, but we're half the population, right?
Right.
Yes.
All right, so
Right.
we've got work to do.
Yes.
Very much.
Thank you very much for joining us.
Thanks for having us.
Thank you.
Yeah, thank you.